Welcome to Q&A with, a show where I focus on the role behind the person to give you some insight into how to operate in their world.
Hello, my name is Davo, and today we have...
Hi, I'm Julia, and I'm an independent nurse prescriber.
Thank you for being here.
Thank you for having me.
So the phrase or term independent nurse prescriber is very unfamiliar to me. Well, until 2 weeks ago, that is.
So an independent nurse prescriber is a registered nurse that has undertaken additional training and has an additional qualification on their registration that allows them to prescribe medication independently of, say, a doctor or a dentist. As an independent nurse prescriber, it's my signature on a prescription, and it's me that takes all the responsibility to make the decision to prescribe.
So are you able to also assess and diagnose a patient?
Yeah, that's one of the key elements actually of becoming a nurse prescriber, is that you have to show that you have undertaken an advanced assessment course so that you are comfortable with diagnosing and assessing a patient. You have to do a physical assessment, a history taking, and then you take all that into account when you're deciding what to prescribe for that condition.
What is the relevance of having the word independent in your job title?
It means that I don't need to rely on anybody else. So, for example, in the aesthetics industry, which I also work in as well as my NHS role, prior to becoming an independent nurse prescriber, I would need to arrange for my patients to all come at the same time, and I had an additional prescriber that would come and meet those patients. So botulinum toxin, or Botox as you probably know it, is a prescription-only medication. So as part of prescribing that medication, it has to have a face-to-face consultation. Now, I would have to arrange for my prescriber to come and meet my patients and pay them, the prescriber, to assess my patients and issue that prescription. Now I'm an independent nurse prescriber, I don't need to involve a third party for that. Earlier
on, you mentioned levels of qualifications.
Mm-hmm.
What qualifications, what routes exist to become an independent nurse prescriber?
So you need to obviously be a registered nurse with the Nursing and Midwifery Council. You need to have a significant amount of experience as being a nurse. When I did mine, it was 3 years. I think it might have gone down to 1 year, but I would have to double check that. You definitely need to have a minimum of 12 months experience in the area that you wish to prescribe in. And then you would apply to university. You need to have some kind of a physical assessment course behind you, and then it's probably about a 9-month course with a lot of work and exams. And then once you submit that, you have to wait for it all to be ratified, and then the university notify the NMC, who then put it onto your registration. So if you search my PIN number on the NMC website, you'll see that I have those additional rights to prescribe. So for nurses, all nurses have a PIN number. Doctors have a GMC registration number. So everybody who is a medical professional that is accountable to a governing body, so like we're accountable to NMC, dentists GDC, doctors GMC, we all have our own individual numbers that people can check upon us if they want to. They are not a registered nurse if they don't have a PIN number.
You mentioned Botox and paracetamol as examples of some of the drugs that you're able to prescribe. Are there any other drugs you're able to prescribe?
So legally, I can prescribe any drug that's in the BNF, which is the British National Formulary. So all the drugs that we can prescribe legally in the UK. As a nurse prescriber, I can prescribe any of those with 2 exceptions. So I cannot prescribe cocaine or diamorphine for the treatment of addiction.
That's a shame.
But also, I can only prescribe within my area of competence. So I've done additional training, obviously in Botox and fillers and complications related to them. So I'm competent in prescribing medications for those. I couldn't prescribe, say, a cardiac medication. Although I've got acute care experience in A&E, I'm not an expert in cardiac medications, so there would be an expectation that I would not go and prescribe a medication that I'm not familiar with.
The whole independent nurse prescriber, that covers a wide range of things in terms of medication, but you've utilised it also in cosmetics. Why cosmetics?
So I always wanted to do aesthetics. Obviously I did years in the NHS before, and I still continue to do that. But within aesthetics, when I went into it, I didn't realise actually how complications can occur, and not being able to prescribe myself, I felt that I wasn't a safe aesthetic practitioner, which is why I then decided to go and learn and develop as a prescriber, so that if my clients, my patients had any issues, that I would be able to directly assess them and prescribe for them.
Are there any courses or mandatory readings that you must take in order to continue being an independent nurse prescriber?
Yeah, so the Nursing and Midwifery Council, we, as nurses, all nurses, whether you're a prescriber or not, we renew our registration every 12 months. And every 3 years we have to revalidate. And part of that revalidation process is that we submit evidence that we've undergone additional training and continual professional development. So whether that's mandatory training for under your NHS role or your aesthetic role, whether you've attended seminars, conferences, reading that you've done, additional training course, you have to, one of the most important things as a registered medical professional is that you are continuing your professional development.
You also work in the NHS.
Mm-hmm.
What role do you have in the NHS?
So I am a junior sister in the emergency department of a very large major trauma centre in London.
So then how do you balance between the two different roles?
So it's a good question because they are so different. But I think that's what I like about it. I like learning lots of different things. I like the chaos of A&E, and you don't know what's coming through the door, and it's so busy, and it's adrenaline all the time. And then I like having that kind of one-to-one time with patients in the aesthetic clinic, making people feel good about themselves in a different way than you do looking after people in A&E. It's very different, but they're both very fulfilling.
So what does your day-to-day role look like?
In aesthetics?
Yes.
If they are new to aesthetics, new to me, or having a new treatment, I get them in and we have a consultation. So we talk about what's concerning them, what we might be able to do about it, undertake a medical history, aesthetic history, and we talk about the mechanism of action of the drug that one might be prescribing or the filler. Any risks, complications, side effects. So we have a really good discussion, and then people will go away and I encourage them to ask many questions. So it's an informed consent process. They are aware of everything before they decide to proceed. I may have people coming back for treatment that have had a consultation, or it might be that somebody's coming back for a review where they've had a treatment. For example, Botox, botulinum toxin, takes up to 2 weeks really for it to take full effect. At that point, we get people back in and see how it's getting on, if they need any little adjustments, things like that. So I work for a clinic in Croydon, and I also have my own space, which is a clinic as well. It's a room that's situated in a health club, which is just mine now. I think most people, when they enter the aesthetics world, will start off working in a salon, where there's a client base and people will come in and the salon refers people to you and you treat them, but then you end up paying a commission to the salon owner. It's a very good experience, it's good exposure, but there comes a point when you kind of resent paying out a lot of commission. So having your own space means that whatever you earn becomes your own. You can control your hours, so you can see people when you want to see them, and everything in that room and that setup is your own. Working for a clinic, it's good because you're with other people and it's fab. It's, you have people that you can discuss things with, have a bit of a laugh with, etc. And then you go home and anything that arises is not your problem, if you like. It becomes the clinic's issue to deal with. It's their responsibility. Not problem, responsibility is a better word. But then obviously you don't earn as much money. So it all balances itself out, pros and cons of having your own space and working for somebody else.
So as you have your own space, what is your fee structure?
It's very difficult because each treatment, it involves different things. So I think probably the easiest example would be Botox, and most people charge per area of treatment. So I think the most common thing would be people having 3 areas of treatment for anti-wrinkle, which would be like the forehead here, like frown lines, etc. So you charge on an area basis.
So as you own a clinic, what is the process from, I guess, working within a salon to owning your own clinic or managing your own clinic?
It's very stressful. So I think the first thing that you need to get is experience, because you don't know what you don't know. You have to be exposed to things to learn from them. So it's about making sure that your insurance is in place, that you have all the equipment that you need and you know what you need. Everything is very, very expensive. And it's whether you decide to go down the route. Some clinics are registered with the CQC. I don't know if you've heard of them, the Care Quality Commission. So they're the people that go and inspect every hospital, every GP surgery, every dental surgery, even private sector where they do like plastic surgery, if you like, on Harley Street. They're all governed by the CQC. Some clinics go down that route. It's very expensive. There's a lot of responsibility, but it means that you can do different treatments. So, for example, as a medical professional, I would have to be in a CQC registered building, to do something called PDO threads, which you may or may not have heard of. They are threads that go into the skin and give a lift. So it's all a bit of a new world to you probably, but there was a big trend not long ago called the fox eye, where people were having these threads and it was lifting up. Ariana Grande was a really good example of people that have got this done. Kendall Jenner, I think.
Of course.
Yeah. So as a medic, I could only do that training and perform that procedure in a CQC building. However, the guy in the petrol station downstairs could go and do a online anatomy and physiology course and then go and train in threads and go and do that thread procedure in his garage tomorrow, because there's no regulation in the industry.
How do you keep on top of new rules?
So I think it's a community that people talk to each other a lot. I read aesthetic related journals. I follow the kind of regulatory bodies that are within aesthetics. So there's the BACN, which is for nurses. I'm a member of a complications expert group. There's always journal articles and research being published that I stay on top of.
You see a lot of patients. What is the most common treatment that is requested?
What do you guess?
Botox?
Yes. Yeah, definitely. And you know what? I get a lot of guys that are having Botox as well now. Brotox, if you like. Yeah, it's really, really popular. I think that the stigma for aesthetic treatments has gone, really, and there's a real move towards natural looking. So people don't necessarily know that you've had a treatment, you just look a bit fresher. So things like there's a treatment called Profilo, which just refreshes, hydrates and tightens the skin. So there's Botox, I would say, is still number one, but other things are coming up, definitely. And a lot of people are taking a lot more interest in their skin now, so a lot of skincare consultations as well.
Do you reckon the interest in skincare is powered mostly because of social media influences?
Yeah, social media, because it allows people to know what's out there. There was a big story that went kind of viral at the beginning of the year with Judy Murray, Andy Murray's mum.
Yes. And
she'd undergone a vaginuderm treatment and then some radiofrequency as well.
Firstly, what are those two treatments?
Okay, so a vaginuderm is a prescription medication treatment, and it's a program where you take it's a very intense skincare program. It's lots of different products, but it basically gets rid of all the pigmentation, it improves your skin quality, it's amazing. So she had undergone that, and then she'd undergone a treatment with a machine called Morpheus 8, which was a radiofrequency microneedling, which is creating wounds on the skin, so the skin repairs itself, and it just regenerates the skin. So if you cut yourself, for example, part of that wound healing response is that you create more tissue to repair that wound. So it's very similar in that sense, the microneedling. So she'd undergone these two treatments and the photos got out and she just looked incredible. And I think that people have seen that and realised actually what skincare can do for you.
Do you have to be careful in terms of applying procedures or medication when it comes to different ethnicities?
Yeah, there are definitely things that you have to take into consideration. Certain skin types will be more prone to pigmentation from damage, so post-inflammatory pigmentation, for example, and then things like chemical peels or certain treatments, we would have to be aware of that when we're treating different skin types. And it's actually one of the things that's been highlighted this week by a platform called Glow Day, which are all about medical professionals within the industry, and the lack of teaching in in aesthetics about taking that into consideration with different skin types. And I think that there is a bit more of a move for people to be educated in different skin types and the kind of treatments. So I think that people with darker skin will tend to go to a practitioner that has their same skin type as them because they understand their skin. But I think it's a bit of a problem in the industry. I think that people, as part of foundation training, it should be a big aspect of it because we're a very diverse community and we should be able to treat all skin types. But people will shy away from it for fear of causing damage or an unaesthetically pleasing result, if you like.
So it's not yet mandatory learning?
No, and I think there's a bit of a misconception that only people with lighter skin tones seek aesthetic treatments, and it's just not the case at all. There's a lot of people that have darker skin types that have pigmentation, whether it's melasma or things from like pigmentation from pregnancy, that kind of stuff. It still happens in darker skin tones. So people do seek treatment, but it's about being safe how you treat them and maybe just taking it a little bit slower or lower strength medications.
So you've covered the most common reasons why your services are sought.
Mm-hmm.
What are some of the worst case scenarios you've had to deal with?
I think that I've had people that have come to me and wanted some lip filler and they've got really bad migrated filler. So the Love Island lips is probably a classic example where people will say, oh, the duck pout, or they've got a bit of a shelf here. And that's basically from multiple filler treatments that's probably been very poorly placed and it's migrated out of the pink lip and onto the white lip here. So you can see it sitting here. In that case, I don't treat them and I advise that they'd be better off having it dissolved and then we start again fresh. So I've turned people away for that. I think as a professional, it's about managing expectation. It's about screening for things like body dysmorphia, people that are probably chasing something that they will never get because they're unhappy within themselves. So there is an element of mental health in what we do. And we have a responsibility as medical professionals to identify when maybe somebody is not right for treatment. What else do I have? I turned somebody away yesterday, actually, who had booked with me for some lip fillers, and we did a consultation, and it turned out that she was actually flying back to the States on Thursday, and I didn't feel it would be safe for me to treat her because if there was any complications or anything that wasn't quite right, she wouldn't be able to return to me. So things like that, it's about identifying things that are further down the line that could happen, or about the kind of result that you would expect.
How much of these procedures or services, how much of it is trend driven?
I think that depends because aesthetics treatments is not just for young people. So younger people will come and they want things like they've seen Kylie Jenner, for example, and they want their lips to be a bit bigger or they want a sharper jawline. My client base is not really young people, probably because I'm not young. I tend to see people that are in their 40s, 50s, even 60s that just want a bit of rejuvenation. And they're the people that aren't really on social media. They're just not feeling good about themselves or they just want to just feel a little bit fresher. I think that with younger people, it is probably social media based where they're seeing that they're seeing something that they want to be and they will come in and they'll show you a photo of someone on the internet and it's about saying, well, this is this person's lips, your lips are unique to you. We can certainly do something to improve them or to make you feel a bit happier, but you're not going to get that.
So you definitely do have that conversation with them, you don't just jump in.
Absolutely, 100%. 100%. I turn people away. I'm not going to take somebody's money if I don't feel that it's safe for me to treat them or we're going to get the result that they want. And actually, only a few months ago, would you believe, it's become illegal to treat under 18s. So people were treating 16-year-olds.
So this wasn't illegal before?
No. It's only just been passed. But apparently it was in the BBC news the other day that there are still unregulated professionals that are treating under 18s. I personally don't treat I've never treated anyone under 18, and most of the time it'd be under 21. If anybody came to me that was 19 that was thinking about lip fillers, we would undergo a consultation and they would have a really long cooling off period to think about it.
Okay, so this is the final question, and it's the most important question.
I know which one it is. Go for it.
What song would you like to include in our playlist?
Oh, I've been thinking about this. I think Driving Home for Christmas. Hi, I'm Julia. I'm an independent nurse prescriber, and you've been watching Salon TV.
If you've enjoyed this video, please do comment, like, share, and subscribe.